Imagine for a second that you are seeking out a cutting-edge cosmetic procedure. You want to enhance your intimate life, maybe boost your confidence. So you do some research, find a clinic, book the appointment, and you get the injection.
Right, and you completely expect that little boost to just stay exactly where the doctor put it.
Exactly. But then, you start to wonder about the actual mechanics of it all. Like, what if this substance injected into your body decides it just doesn't want to stay put? What if it, well, goes for a walk?
It sounds like pure science fiction, I know, but it is actually entirely biologically plausible. I mean, we tend to think of our bodies as these static containers, almost like mannequins.
Yeah, like you just put something in there and it stays in total isolation.
Right, exactly. But the reality is our human anatomy is incredibly dynamic. It is constantly moving, shifting, and exerting pressure on everything inside it.
So today's deep dive tackles a highly specific, slightly taboo, and honestly, incredibly fascinating question. Can the filler used in a G-shot procedure actually move or migrate after it's been injected?
It's a great question because it sits right at the intersection of booming aesthetic trends and incredibly complex human anatomy. We are basically looking at what happens when modern cosmetic desires collide with the unyielding laws of physics.
To get to the bottom of this, we are unpacking a really diverse stack of sources today. On one side, we have promotional materials from cosmetic clinics. Those glossy brochures promising incredible benefits and pushing vaginal fillers as a quick, risk-free lunchtime fix.
And on the other side of that spectrum, we have some very stark, very serious clinical warnings from the American College of Obstetricians and Gynecologists, or ACOG.
Yeah, and bridging the gap between those two extremes is this wild medical case study from a clinical journal. It's about a pregnant woman dealing with a severe complication caused by migrating filler from almost 2 decades ago.
That specific case study completely upends the traditional narrative we are often sold, about the lifespan and movement of cosmetic injectables. It really forces us to look at the long-term reality.
Okay, let's unpack this. Because to understand if this material moves, we first need to establish exactly what is being injected and where it's going.
Right. To begin, we have to clarify the anatomy itself, because the term G-spot is largely just a commercial and cultural misnomer.
Right. I was reading through the anatomical descriptions, and the clinical literature says it's not a distinct magical anatomical button.
No, not at all. The medical texts actually refer to it as the clitorethrovaginal complex, or the CUV complex.
Which sounds less like a single structure and more like, I don't know, a busy intersection of different tissues.
That is a very accurate way to describe it, actually. The CUV complex is a functional, highly sensitive zone. It's the area where the internal roots of the clitoris, the crura, and the female prostate interact very closely with the urethra.
And this whole interconnected zone is located about 1 to 2 inches inside the anterior or front vaginal wall, right?
Exactly. It is a complex network of nerves, blood vessels, and glandular tissue. So when a clinic performs a G-shot, which they sometimes call anterior wall augmentation, they're targeting this specific intersection.
But reading through the clinic descriptions, I noticed there are a couple of different procedures marketed for this area. Some of them talk about using your own blood, and others talk about injecting a gel.
Yeah, you are hitting on a crucial distinction there. The G-shot is fundamentally different from something like the O-shot.
Right. The O-shot is the one that uses platelet-rich plasma, or PRP, spun down from your own blood.
Yes, and the theoretical goal there is to use growth factors to regenerate nerve endings and blood vessels. It's a liquid that absorbs completely into the tissue. The G-shot, however, involves injecting 1 to 3 milliliters of cross-linked hyaluronic acid dermal filler.
Wait, that's the exact same kind of synthetic HA gel people get injected into their lips or cheeks, isn't it?
It is the exact same material. So the goal of the G-shot isn't to magically grow new nerve endings. The goal is entirely structural.
I was thinking about it like putting a speed bump on a racetrack. You are placing a physical mound of gel directly into the submucosal space of that vaginal wall to create a physical protrusion.
I like that analogy. Yes, it creates physical bulk to increase friction and contact during penetrative intimacy. But because you are introducing a foreign viscous gel to artificially alter the topography, the risk of that gel flattening out or migrating becomes the primary mechanical concern.
I have to admit, when I first started looking into these sources, I had a fundamental misunderstanding about how these fillers work. I thought fillers were temporary and just dissolve naturally after 6 to 12 months.
That is perhaps the most pervasive marketing myth in the entire cosmetic industry.
Wait, really? Because if they just disappear after a year, how can migration be a long-term issue at all?
Well, the idea that HA filler simply evaporates after a year has been completely debunked by recent medical imaging. Our sources reference several advanced MRI studies conducted on patients who received filler injections years prior.
Oh, wow. And what did the scans show?
They show that hyaluronic acid fillers can actually remain present in the body for up to 15 years.
15 years. That completely changes the timeline. If it's in there for a decade and a half, the fact that the visible physical bump goes away doesn't mean the filler dissolved. It just means it moved.
Yes, exactly. The initial aesthetic effect diminishes as the filler gets pressed flat or integrates into the surrounding tissue. It gives the illusion that it dissolved, which prompts people to go back and get more injected.
Meanwhile, the actual synthetic gel substance is still there, just sitting deep in the fascial layers, traveling away from the injection site. So what actually causes it to move in the first place?
The clinical literature breaks down the mechanics of migration into a few key factors. The first is poor technique. If a practitioner injects the gel too superficially, or if they inject far too much volume into a space that cannot anatomically accommodate it, the internal pressure simply forces the gel to escape.
It's basically the equivalent of trying to overfill a water balloon.
Yeah.
Eventually, it has to bulge somewhere else, right?
Yeah, precisely. Another major factor is something called G prime, which measures the structural integrity or firmness of a filler.
So using a soft filler in a highly mobile area is a bad idea.
Exactly. If you use a filler with a low G prime in an area that experiences a lot of movement, that soft gel is going to get squished out of place almost immediately.
And the body isn't static anyway. I was amazed by the part about hydrophilic expansion. HA fillers actually love water, don't they?
They do. Hyaluronic acid acts as a molecular sponge. Once injected, the filler begins to absorb natural fluids from the surrounding tissue, sometimes expanding to double its original volume.
Wow, so you have a substance swelling up inside a confined space, creating pressure that forces the gel to seek the path of least resistance.
Yes, and then you add the constant mechanical pressure of muscle activity. Repetitive muscle contractions literally squeeze the gel through the microscopic pathways in the tissue over time.
I think the strangest mechanism in the literature, though, was lymphatic spread. The idea that it doesn't just push through tissue, but actually gets transported.
It is relatively recent and somewhat alarming. Ultrasound studies reveal that microfragments of the filler can be absorbed directly into the body's lymphatic channels. Researchers have documented filler material migrating all the way to lymph nodes in the neck after being injected into the face.
That is wild. So taking all these general rules of filler migration, we have to apply them directly to the G-shot and the pelvic region. Here's where it gets really interesting. The vaginal wall during sexual intimacy is the textbook definition of a high-friction, high-pressure muscle environment.
It absolutely is. When you view the pelvic floor through the lens of structural mechanics, it is arguably one of the most mechanically stressed environments you could possibly inject a soft hydrophilic gel into.
If simple facial expressions can move cheek filler over time, what does penetrative sex do to a G-shot?
The logical conclusion is that the gel is going to get flattened and pushed around, which is exactly why the medical establishment is raising red flags.
Because if the filler shifts from its intended target down there, it doesn't just look strange, it actually causes functional issues.
Exactly. The CUV complex is such a crowded anatomical neighborhood. The most immediate risk is urinary retention. The area targeted for a G-shot sits directly adjacent to the urethra.
So if that filler absorbs water and expands or gets squeezed slightly off-center, it can literally compress the urethra.
Yes, making it incredibly difficult and extremely painful for the patient to pass urine.
This definitely explains the stark warnings from ACOG. Their committee opinion explicitly states these procedures are not medically indicated, and they list potential complications like altered sensation, severe scarring, adhesions, and dyspareunia.
Dyspareunia is the clinical term for chronic severe pain during sexual intercourse. It is a devastating complication. You have patients seeking a procedure to enhance their intimate life, and they end up with chronic pain because a pocket of migrating gel shifted into a nerve pathway.
To truly illustrate the power of filler migration, we have to talk about that jaw-dropping case study, the 45-year-old pregnant woman.
Oh, the clinical details of that case are just profound. So this woman is pregnant with her first child and requires an elective C-section at 36 weeks. During routine care, technicians couldn't get clear ultrasound images of the fetus because the tissue in her lower abdomen was so dense.
Right, so the doctors assume it's just unusual tissue and proceed with the C-section. But when they make the incision, what do they find?
They find that the fascial layer was completely bound up. It was entirely restricted by a massive, stiff web of migrated filler deposits sitting right between her fat layer and the muscle fascia.
Literally gluing the tissues together.
Yes, it made the extraction of the baby incredibly dangerous. They had to make unplanned surgical incisions into her fascia just to create enough stretch to get the baby out safely.
And the craziest twist to this medical mystery is where all that filler came from. Because she hadn't had any abdominal procedures.
No, she hadn't. When they took a detailed cosmetic history, they discovered that 17 years prior, she had received large volume filler injections into her breasts.
17 years. So gravity and time pulled the filler all the way down from her chest, across her rib cage, and settled in her lower abdomen.
Yes, and the journal notes that by the time she was 36 weeks pregnant, they could actually feel the migrated filler extending all the way down into her vulvar region.
That is just insane. If filler can migrate all the way from the chest to the vulva over 2 decades, injecting filler directly into the dynamic tissues of the vaginal wall certainly carries a massive logical risk of local migration.
It absolutely does. It brings up very serious questions about long-term tissue compliance and permanent detrimental changes to natural stretch and function.
So if a listener or someone they know has had this procedure and they suspect the filler has migrated, what can be done? Are they just stuck with it for 15 years?
Fortunately, there is an antidote. The medical response is the injection of an enzyme called hyaluronidase. It is an enzyme naturally produced by the body that can rapidly dissolve HA filler.
Oh, like a magic eraser. I read it acts like a pair of molecular scissors, right?
That's a great way to put it. It actively cuts the bonds holding the hyaluronic acid chains together, turning the firm gel back into a watery liquid that the body can just flush away. It usually works within 24 to 48 hours.
Wait, so if there's a magic eraser that works that fast, what's the big deal? Why is ACOG so worried if doctors can just dissolve it?
It seems low risk until you understand the collateral damage. Hyaluronidase cannot tell the difference between the synthetic filler and your body's natural hyaluronic acid.
Oh no, so it dissolves your own tissue too.
Yes. If a practitioner uses too high a dose or places it inaccurately, they actively dissolve the patient's natural tissue volume. You could go in to fix a lump and end up with a permanent structural deficit.
So the antidote carries its own massive risks. Plus, cosmetic clinics market this G-shot as a quick 15-minute fix, but medical bodies like ACOG stress that there are zero long-term studies on the safety or migration rates of these specific intimate procedures.
Exactly. There are no massive clinical trials for this. Clinics use products FDA approved for the face-off label for the pelvic floor, assuming the same safety rules apply despite the massive mechanical differences.
So distilling all of this down, the G-shot offers a temporary physical augmentation, but the science of HA fillers proves that they can and do migrate, especially under the pressure of dynamic muscle movement.
The ultimate takeaway for you listening is to change how you view cosmetic enhancements. They are not just surface-level tweaks. You have to view them as medical implants that interact with your body's mechanics, gravity, and time.
Which really leaves us with a final, lingering question to ponder. As we develop more advanced injectables to chase aesthetic perfection, are we prepared for the reality that the substances we put inside ourselves today might end up in a completely different part of our bodies decades from now? Or maybe the future isn't about synthetic gels at all, but using our own stem cells to safely reprogram our anatomy without the risk of a wandering implant.
It is a fascinating horizon to watch, for sure.
It really is. Well, that wraps up today's deep dive into the mechanics of wandering filler. Thanks for joining us.